impact of strep on children in Israel, Turkey, and the US. Following that will be a Q&A session as we've done before in the other panels. Speaking first will be Dr. Hilla Ben-Pazi. She's a child neurologist and medical entrepreneur, director of Pediatric Movement Disorders, Neuropsychiatric Unit Shar Zedek Medical Center in Jerusalem, Israel.
Thank you, Diane, for organizing this. It's amazing, the strength of parents. It's a pleasure to be here today, and I would like to tell you my personal story, or more correctly, the story that my patients told us. And this is a story. Oh, first a disclaimer. I'm a founder of a telehealth company. It's called Neurocan for Accessible Services, Neurological Services. This is unrelated to my Sydenham's chorea work, of course. So we're going to walk through the clinical symptoms of these patients, the pathophysiology, and speak a bit about treatment. So I'm going to present 5 cases from, I think it was 35 cases, but these are the cases that I've learned the most from. And we're gonna jot some ideas down and see, hopefully you'll agree with me. You don't have to agree with me. But just a reminder that Sydenham's chorea, that definition and diagnostics relies on the clinical symptoms. And the clinical symptoms, namely chorea, the movement itself. Chorea is a medieval dance of the shoulders, movement of the shoulders. You can see this still in Ethiopia. We don't dance this way today, but it's an interesting dance, and these are little small movements. This was named chorea, but these kids could have other movement disorders, but usually it is chorea. There's no clear criteria because, as we've heard earlier, the antibodies could be gone by then. And it's about 30% of the people who have rheumatic fever can have Sydenham's chorea, and that's the only criteria. So chorea, Sydenham's chorea is really a definition of exclusion. So you really have to sort of rule out the other stuff in order to diagnose Sydenham's chorea. So this was my first patient. The first video, she came to me many years ago. This is the second time she came to me. And this time she came after summer camp when she forgot to take her medication, her anti-strep. And I thought, okay, this chorea, and you can see there's a lot of movements here. I thought, that's because she forgot the prophylactic medication. And then a couple of years later, she comes back again. And this time she took the medication, everything was normal, she didn't have any infection, and she just had a bout of chorea. Now what you can see that the chorea can be very, very mild. There are these little movements, and I'll give you a clue there. What happens, you need to ask the child to spread out his fingers, because when they do have the chorea, they feel uncomfortable. So they tend to limit the range of motion. So they sort of go like this and like this. So you have to ask them to spread out their fingers, okay? So that case made me think, well, what was the reason for the second recurrence? It wasn't the antibiotics. And then I saw this child. This child, actually, I haven't seen her with chorea. She came to the ER, and she had acute mitral regurgitation, so the cardiologist gave her steroids. And she has only a very, very slight chorea, and you see they brace themselves. And she has very, very mild chorea. And I told myself, this child that had a month of steroid treatment, I'm not going to see any recurrence, right? Because we treated her inflammatory disorder. But lo and behold, a year later, she comes in with chorea. And you can see all these extra movements. And the kids sort of move around. Some of the movements are voluntary because they're trying to mask their movements. So they sit on their hands, and they don't feel comfortable with the movements. And I said, wait a second, something's happening. It's not, the steroids are not working, right? Because we have this recurrence. And actually, it's in the literature. When we look at the recurrence of Sydenham's chorea, so there are a lot of things that affect the recurrence, like persistent chorea, which really is recurrent and persistent are probably the same thing, and irregular penicillin prophylaxis, that's obvious. But you know what isn't on the list? Steroid treatment. Steroid treatment does not play a role in recurrent Sydenham's chorea. So, what we know, we can pin to this board that penicillin prevents recurrence, but steroids do not. So, we know that obsessive-compulsive symptoms are a part of the non-motor clinical symptoms of Sydenham's chorea. And we know that there are a lot of non-motor symptoms in Sydenham's chorea. The main thing is the behavioral change. The psych disorders are less common, and also we have cognitive issues. This is the same disorder, Sydenham's chorea always has psychiatric disorders. If you don't look for them, you won't find them. And what is interesting and worrisome the most, I think, is what we heard this morning about the non-motor symptoms over time. Because, eventually, the chorea usually goes away, usually. But when you look at the timeline, you can see that these kids have some sort of predisposition, because when you look at their prior symptoms, some of them had higher rates, for instance, of ADHD beforehand, okay? And then when you look on the time scale, like years after, is the severe psychiatric issues that are extremely bothersome. Because we know from both, actually I had the privilege of speaking with Willocks that did these studies. So he found a higher history. He was a psychiatrist, and he found higher rates of Sydenham's chorea among his patients, and then he did a prospective study, and he found the same thing. So it's really worrisome, and so there's sort of a timeline here. Maybe there's sort of a predisposition, a neurological predisposition. Then you have chorea, the inflammation, and then you have the late effects, which from my point of view are the most worrisome. So what we see now is that long-term psychiatric issues are probably not related to the chorea itself or the amount, and there could be an abnormal neurological history previously. So what do we know about autoimmune disorders? This child was actually, I think he's the only non-Ashkenazi in the study. And he came in with tonsillitis. And because he didn't like throat swabs, he didn't get a throat swab, he didn't get treatment. And he had temper tantrums. Eventually, he developed hemichorea. And he felt that insects are crawling over his body. So we discontinued the haloperidol. We thought, it's probably treatment. But then he started hearing voices. He couldn't stay home alone. And eventually, he did the whole workup, and he had mitral regurgitation. But he was among the 6% who did have a brain lesion. And look, it's located just in the anterior part of the caudate nucleus. So this is the basal ganglia here. Okay. And here's the lesion. And this is interesting because we know the basal ganglia has 3 circuits. We have the emotional processing seen in red, which is anterior. And then we have the motivation in orange, cognitive and executive in yellow, motor planning, and then motor execution. So this guy had a lesion in the anterior aspect, which is really the psychiatric location within the basal ganglia. The first study we did with Madeline, so I've done a bunch of animal studies which were unsuccessful, and eventually we sent the sera to Madeline, and these are the initial results. You can see that we have higher titers of anti-D1 and anti-D2 receptor, anti-dopamine receptors, and we thought this is pretty logical because the dopamine can really explain both the psychiatric and the movement disorders. We treat the movement disorders with anti-dopaminergic medication. And we sent these sera to Dale as well in Australia, and he actually found both also the D2 and D1, but the D1 were under the certain threshold they had, so they published only the D2. But here you can see that these patients have anti-D2. These could be also found in Tourette, but in lower levels. I think the most interesting fact that these antibodies correlated with the clinical symptoms. So it made sense that that the dopamine system is involved, but we were very happy to see that the titers really were related to the clinical symptoms. And the clinical symptoms in the Unified Sydenham's Chorea rating scales are both the neurological and psychiatric. So it's both, okay? So you see that there is a correlation. And now, this is a new study. It's unpublished yet. And in this study, we did a bunch of antibodies. I mean, Madeline did. I just put on the slide. And we collected sera from children who had tonsillitis, children whom we knew didn't have tonsillitis, and Sydenham's chorea, both acute and chronic. And what we can see is that the acute Sydenham's chorea had higher titers. That's obvious. But over time, this is the interesting slide, I think. The interesting fact is that when you combine the titers, during the acute phase, actually the kids who have strep tonsillitis have higher titers. But these, after about a month, they go away. But guess what? In kids with Sydenham's chorea, they have higher titers over time. So it's a combination of anti-basal antibodies over time. So time here plays probably a crucial role. So if you have a strep infection and you know how to lower your titers, you're good. You're probably going to be good. But if you have either, it could be that you had previous infections and that's the reason you're not lowering your titers, or you have a genetic predisposition, or God knows what. But if these antibodies remain high, this is not very good for your brain, probably. So it's not a single antibody as we thought. Some of them could be innocent bystanders, some could not. Could be that there are other antibodies involved that we're not aware of, but it's probably a panel of antibodies, something like, in other autoimmune diseases. So it's not a single antibody, and it's over time. So I thought I've seen it all. And here you see a child. This is a family that I've previously seen their son, and the father texts me, and he says, my child has Sydenham's. And this really teaches you always listen to the parents. I said, what does your son have? He said, he has this movement. He has chorea of his tongue. I said, no. Chorea of the tongue? He has to be examined, properly. Obviously, he came in and he had chorea of his tongue and his fingers. And then I gave him carbamazepine, and they came in again, and mom says, can you check the other child? I said, why? He has the same thing. No. And they dressed like twins, but they were a year apart. Their older brother had Sydenham's chorea, and now these two, they look exactly the same. And father said, you have to take a picture. But the only difference is that the older child already received Tegretol. Now you're going to see their chorea. And their chorea, you have to see it. So the chorea, so this guy had Tegretol. You see, he doesn't have any chorea anymore. Look at his brother. His brother does. Oh, it's running slow. Anyway, you could see that really there is an effect here. Oh, it's not working. Never mind. You'll have to believe me. So there's this mild. So the tongue is the same, and the chorea of the hands is different. Anyway, we have 3 such families with siblings who had Sydenham's chorea, not in the same time. This was the only family who it occurred in the same time, and they're all Ashkenazi. And we have a lot of Ashkenazi patients, like 75% of our cohort is Ashkenazi. And this led us to think that there's something about the familial tendency and genetics, and we're hopefully going to do some genetic studies. I'm going to finish with the treatment, and we're going to run here very fast. And this is the child you've seen before, and we don't need the video to show you what I wanted to demonstrate. So what happened, he got a lot of medications which didn't help, so we eventually gave him pulse steroids, and his chorea remitted. But the amazing thing was that he said that after 48 hours, this is the first day that the thoughts do not go into my head. And he received a lupus regimen, steroids for a year, and his follow-up MRI showed that the lesion that we saw before just went into gliosis. And you know the big difference between these 2 videos, obviously he doesn't have chorea, not because movies are not moving, because he didn't. But I want you to notice what is the big difference between them. Most people say, the students usually say, oh, now he has steroid side effects on the lower video. But the difference, he's smiling. When the child starts to smile, then you know he's okay. Okay? I'm going to end with this child who came in with Sydenham's chorea, but her chorea wasn't as bad as her personality changed. She was the oldest child of a family, and she was always the responsible person there. But then, when she had chorea, mom noticed that she wouldn't clear her plate off the table. And she would burst into tears. She didn't notice. And what she had is a psychiatric symptom called abulia, which is extremely common. It's actually the most common symptom in cauda nucleus injury in adults. And I call this Garfield syndrome. It's like in teenagers when you ask them, do you want to read the book? So they say no, but then you bring the book and they keep on reading for hours. So it's a problem in initiating something. Initiation is motivation. So what happens with these kids, they have a lack of motivation, a lack of association, abulia, and this is common in children with the cauda nucleus lesions. And so we gave her a bunch of therapies, but she wasn't doing okay. So at last, the parents asked for steroids. We gave her steroids for 3 weeks. She was okay for about a year. After a year, mom said, she's not herself. She's still not herself. And the parents were informed of the other family who received the harsh, the 1-year protocol, and they requested to have the same protocol. And she just got married last year. She's doing okay. Actually, the first child and also got married 4 months after. So I feel that. So we did publish these cases, and when I presented it in multiple neurological conferences, I think that most neurologists feel that for severe psychiatric symptoms, we can and should think about long-term treatment, because the short-term treatment, namely the 3 weeks of steroids, may not be sufficient. So I'm leaving you there with these thoughts. So if you see a child with Sydenham's chorea, you can consider a long protocol. And for the psychiatric sitting here in the audience, and pediatrician, I urge you, look for the chorea. It's not evident. You have to look for it. Okay, you have to ask the child to spread out his finger and watch. And you have to compare your fingers to their fingers. And the fact that you don't have chorea and the other child moves about, rethink. You can't call PANDAS if the child is doing like this. This is chorea. Okay, that's Sydenham's chorea. Okay, this is chorea. So, and this has implications because you need prophylactic treatment. So, take-home messages. Document neuropsych symptoms. We have the Unified Sydenham's chorea scale you can use. You have to consider other antibodies, genetic factors, and consider long-term treatment for selected cases. I'd like to thank the team, Madeline, and the Oklahoma Center, and I got funding from Mirsky Foundation. Thank you.
Dr. Gonca Selek, Kukurova University, Adana, Turkey. She's an associate professor, Department of Child and Adolescent Mental Health and Disease. And she sees a lot of PANDAS and PANS children in southern Turkey. So glad you could come.
Hi, everyone. It's an honor for me. I am thankful, Diana, who kindly invited me. I want to share about our clinical experiences southern area of Turkey. These are topics, two parts of my presentation. Firstly, I will talk about our clinical experiences. Secondly, immunogenetic studies. And lastly, hypotheses about genetics in the future. As you know, autoimmunity and its effect on neuropsychiatric disorders are still unknown efficiently yet. Severity of symptoms could reflect on complex interactions of immune system, environmental factors, genetic, and ethnicity. There is evolving concept from PTANS to PANS to understand etiopathogenesis and other factors. This is first study I want to talk about, the Turkish journal Mental Health, it's present. We aim to investigate the frequency of familial autoimmune history in PANDAS OCD cases and ANA anticorps. We screened all patients with key sets to diagnose psychiatrically. We have 91 OCD patients, most of them PANDAS, and ANA positivity was most common in PANDAS group. Familial collagen tissue disorder or autoimmune history, 34 patients, most of them rheumatoid arthritis, and respectively vitiligo, non-specified collagen tissue disease, psoriasis, Behçet disease, ankylosing spondylitis, celiac, systemic lupus erythematosus, multiple sclerosis, and FMF. When we divided the groups according to familial autoimmune history, medical history of patients, especially tonsillectomy and penicillin prophylaxis, are more related to the familial autoimmune history. And consistent with other findings with literature, being male, early onset, penicillin prophylaxis, tonsillectomy, and especially ADHD comorbidity was more prevalent in PANDAS group. When we divided groups, subgroups, PANDAS, non-PANDAS, PANDAS variant, and total OCD, familial acute rheumatic fever, familial OCD was more common in the PANDAS group, and also ANA positivity. As you know, ANEA may be 10% in the normal general population. But it was, when we compared normal population, it was high. Familial autoimmunity, in my opinion, is important to detect pediatric autoimmune neuropsychiatric disorders. This is our case series, 12 trichotillomania patients. We searched maternal immune conditions, PANDAS, and trichotillomania relationship. We have 12 trichotillomania patients. 4 of them had maternal autoimmune history, 5 of them maternal allergic disease. Only 2 patients had no maternal immune history. Such a little group, I think it's very high rates for maternal autoimmunity. Genetics important, but recently autoimmune ecology as a new concept claims that environmental factors may be more important rather than genetic susceptibilities. Smoking, vaccines, coffee, vitamin D, microbiota, etc. As you know, vitamin D is a bone marker, fat-soluble vitamin. But recently, neurosteroid, anti-inflammatory, immunomodulator, and neuroprotective molecule. The reported biological effects of vitamin D in the nervous system include neurotransmitter synthesis. Prenatal period, hippocampal neurogenesis is related vitamin D decreasing. In an experimental animal study, MOP and vitamin D combination decrease autoimmune encephalomyelitis. Additionally, during development, vitamin D deficiency is related apoptosis-based gene expression. These are mostly researched neuropsychiatric disorders about vitamin D and immune system. We have a patient with acute-onset OCD after the streptococcal infection. He admitted to our clinics, checking and washing compulsion. He cannot look mirror because of when he look at mirror, the sexual things, he claims that sexual things seems. And then his vitamin D level is very low, ACO level very high. And firstly, we didn't give any antibiotic treatment. Firstly, we have replaced vitamin D in daily 800 international unit. After 4 weeks, his compulsions decreased according to Yale-Brown Obsessive-compulsive scale, but obsessions about sexual things minimal remain. Then we planned the case control study about vitamin D deficiency and possible association with PANDAS. We have 30 patients PANDAS OCD and 20 patients control. At first look, there was no significant differences between PANDAS patients and control patients, but when we divided the groups according to vitamin D status, all the patients, deficiency group, all patients in the OCD with PANDAS. Additionally, OCD comorbid ADHD, more related bone catabolical changes. For example, parathormone, alkaline phosphatase level, more high in the ADHD comorbid OCD group. I want to talk about another study, immunoglobulin A, DSM-5. According to DSM-5, you know, it's a new concept. Immunoglobulin A, PANDAS, and DSM-5 OCD-related disorders. We have 58 patients, most of them OCD, and the others trichotillomania, body dysmorphic, hoarding disorder, and comorbid conditions. Familial OCD, is 74% in all patient groups. According to familial OCD, immunoglobulin A levels were lower in the familial OCD group. There were more data, but I can talk about briefly. Similarly, PANDAS group, EGA were lower than control group. Interestingly, familial autoimmunity is related recurrent infection, tonsillectomy, acute traumatic fever, OCD in familial history, and sensorial hypersensitivity of patients is more related in the familial autoimmunity groups. Yes, let's talk about. When we divided group OCD and OCD spectrum, EGA, both of OCD and OCD spectrum were more lower. But in my opinion, ACO levels are more valuable than immunoglobulin A to detect autoimmune neuropsychiatric disease, but maybe immunoglobulin A related the phenotypic characteristics of patients. It's in my opinion. I want to talk about autoinflammatory disease. Autoinflammatory disease and autoimmunity are distinctive pattern on immune system. Autoinflammatory doesn't need any infectious trigger. Infection begins and persists. Even no infection history. The inflammation occurs and remains maybe lifespan. These are mostly seen in Mediterranean region, in our region, periodic fevers. Our rheumatology, immunology department had 500 FMF patients. Lastly, genetic mutation, most of them genetic mutation, 300. The others one, diagnoses are clinical based. This is our case report. The periodic fever and hyperimmunoglobulin D syndrome with PANDAS. He has comorbid ADHD and OCD. During fever attack, his motor and vocal tics has increased. As you can see, familial autoimmunity and familial OCD are very clear. We referred him pediatric rheumatology department. They didn't find any FMF gen, but mevalonate gen mutation was determined. Pharyngeal culture was negative, although also high. ACO titer was high. This is second part of my presentation. These are my kittens. Grandsons, yeah. Genetic susceptibility is different. It depends on many factors. Environmental factors trigger your genetic susceptibility. Familial ancestral continuity, your living area, geographical condition, all of them cumulated for trigger your genetic susceptibility. But being a carrier of any genetic mutation doesn't mean that you will have a disease. I want to talk about mannose binding lectin protein. This is our study. It is an important humoral innate immune system. It provides first-line defense and also activates the complement systems. Patients with MBL deficiency exhibit an increased vulnerability to both infectious and autoimmune disease. Estimated prevalence is 25–30% in Caucasian population. Sometimes MBL called as acute phase reactant, but it is early ambitious terminology, I think. This is a study claims that MBL substitution treatment may provide benefit in chemotherapy-induced neutropenia patients. They found increasing MBL-mediated complement activation, although suboptimal changing MBL serum levels. This is our study. It's still ongoing. I can share briefly. We have 102 patients, OCD patients, mostly PANDAS patients, and we screened MBL gene mutation, codon 54 polymorphism, and any variant of MBL gene variation, more frequent in OCD groups. And we did regression, logistic regression analysis. MBL gene was found in 14-fold increase in PANDAS group. But our healthy control group is small. It's our limitation. This is my colleague's Ayşegül Tahiroğlu studies. TNF alpha 308 gene mutation seems like that related with PANDAS patients. And I want to talk about lastly hypothesis. Especially autoimmune conditions may be more common in Mediterranean region. Specific genetic ethnic background may be related to high prevalence with autoimmune disease. Thalassemia is the most common hematologic disease, disrupted globulin production, autosomal recessive inherited in certain geographic area. Genetic prevalence is more common in our country, especially Mediterranean region. However, silence carrier state and its clinical importance are not well known. As you can see, 1 to 20% the beta thalassemia carrier state reported, especially Icelandic and sea coast area. Turkey is one of them, and our city, Adana city, is maybe 13% thalassemic carrier state. This is another our study. We estimated 20% in the PANDAS group thalassemic carrier state. This is our country map. As you can see, the coast of the Mediterranean and Aegean Sea. This is Adana city is mine, and Hatay, Mersin, the nearest city is most prevalent in thalassemia carrier state. Sometimes our friends ask me why your patients are so high. And then we planned, okay, we can research why are high. It is possible that thalassemic carrier state is most prevalent in this area. It is only hypothesis. Thalassemia and autoimmunity relation stated by Altınöz. Thalassemia heterozygote mutation and carrier state may change hemorphin molecules. Hemorphin molecules associated with suppression of inflammation and neutrophil migration, and thalassemia heterozygous and carrier state might prone to autoimmunity for hemorphin suppression. Do you know malaria? Of course. This is ancient time history. When you gain malarial resistance, you can be a hemoglobinopathy. Hemoglobinopathies are protective to malarial resistance. This is evolving process of hemoglobinopathies. I can summarize this presentation. You can born some genetic susceptibilities. You can have any familial autoimmunity and any other rare disorders and immune abnormality. But when you confront some environmental factors, and especially stress, traumatic experiences, cortisol, you can experience onset of the neuropsychiatric disorders. Additionally, there is ongoing immune development and ongoing brain development. Reciprocal and longitudinal relationship there is with epigenetic background. This is our university and first Parents Awareness Day of Turkey. These are my colleagues. And I hope to come our country in future. Thank you.
Next, we'll have Dr. Madeline Cunningham speak. She's from the University of Oklahoma Health Science Center, College of Medicine, George Lynn Cross Research Professor of Presbyterian Health Foundation, Presidential Professor, Department of Microbiology and Immunology at the University of Oklahoma. Nice to see you. Hi.
Thank you. Well, I would like to thank Diana for this beautiful meeting. I think we should give her applause. Thank you. And I'd like to say that I'm amazed since this morning. I sat way back up there in the corner and tried to say very little, and I'm just amazed at what all of you said, because I remember when we started out and we had nothing, and now we really have something, and it is amazing, and it's thanks to all of you that have made it happen. So I will be talking to you today about the pathogenesis of group A streptococcal sequelae, because I've spent my entire life, scientific life, looking at various sequelae of streptococcal infections. I have a few disclosures, but I would like to thank many of the organizations that have supported me over the years, especially the National Institutes of Health, the National Heart, Lung, and Blood Institute, which we've received funding from for almost 30 years, that has kept our lab going, the American Heart Association, NIMH, ADA, the Oklahoma Center for the Advancement of Science and Technology, the OCD Foundation, PepsiCo, the David Judah Fund, Autism Speaks, and the Autism Research Institute. And my financial affiliation, as most of you know, is Molecular Labs. Group A streptococcal diseases are many, and I think you have probably heard about pharyngitis and impetigo and many of the diseases, and you've heard mention of rheumatic fever, which we have studied as one of the group A streptococcal sequelae. It has several manifestations, but the one we will focus on today is Sydenham, chorea, although I have spent a lot of time investigating carditis. Polymigrating arthritis is probably the most common and is painful, but is not so injurious as the carditis and the Sydenham chorea. Skin manifestations include erythema marginatum, or subcutaneous nodules, and there is a new revision of the Jones criteria in circulation as of 2015. The pathogenesis of group A streptococcal infection, you certainly heard an absolutely beautiful lecture by Dr. Cutforth earlier today talking about the pathogenesis of streptococcal infection, so I certainly don't need to talk too much about that, but I would like to say that the group A streptococci, of course, adhere at the epithelium, and they are into your sinuses, into your throat. This is where the Th17 cells are that Dr. Cutforth was talking about, just to kind of make it understandable for all of us in case you got overwhelmed by too many immunology terms. But it was beautiful because as we have infections over and over and over again, especially children, in the sinuses and in the upper respiratory tract, the Th17s are activated again and again and again. And I can tell you from my own data of rheumatic heart disease, the hearts of rheumatic fever patients are full of Th17. And that's the chain that links the heart to the throat. That was Dr. Wanamaker's quote, for those of you who remember him from the University of Minnesota. And so then the group A Streptococcus expresses antigens that are recognized by these B and T cells. And of course, that activates B and T cells, and we get cross-reactive antibodies. And we get them with all infections. And that's why you heard the wonderful presentation about the associations where several million people were studied. And the infections are related to autoimmunity, and they're related to mental disease. And the reason is because of this very thing that I'm talking about. It's not just about strep, although streptococci are our great example, and they have been the path to show us what happens in autoimmunity and infection and molecular mimicry, which comes from all of that. So the molecular mimicry definition is the sharing of antigenic determinants between host and invading organism, and two of the most offending antigens on the group A Streptococcus is the M protein and the group A carbohydrate, mimicking proteins in the heart and in the brain. And we focus on Sydenham, chorea, neuropsychiatric disease. I don't really need to go over these because they've been addressed earlier. So if we study further, the first 50 cases, we had 22 PANDAS cases and that were from NIH, and 8 Sydenham chorea cases that we looked at, and Tourette's, OCD, and ADHD. Those came from Dr. Leckman, Dr. Jim Leckman at Yale. And you can see that they are reactive with lysoganglioside directly on the ELISA plate. And this is also related to reactivity with the caudate putamen region, and it reacts with the Sydenham chorea monoclonal antibody 24 and with a commercial anti-ganglioside antibody. And you can see the blobs of antibody on the surface, whereas an isotype control is blue, it's negative. So the mimicry in Sydenham chorea, just to make a long story short, is that the streptococcal epitope, which I didn't show you the data, is the group A carbohydrate epitope in acetyl beta-D-glucosamine, and then the antigens lysoganglioside and tubulin in the brain. But the chorea monoclonal antibodies and chorea sera also demonstrate cell signaling through the calcium calmodulin-dependent protein kinase 2 in the neuronal cells. And this was shown, we were very fortunate that one of the 3 monoclonal antibodies actually signaled neuronal cells to activate CAM kinase. And the donor serum, which of course you don't want the monoclonal to be this minor event that's not the truth from this donor serum, but the donor serum was positive, and 3 months later we saw her again, or 6 months later, and the convalescent sera was not signaling at that time, and she was well. Dr. Sweeto was kind enough to provide acute and convalescent sera from the NIMH, and they also demonstrated similar reactivity and similar lack of reactivity in convalescence. And this mechanism of the antineuronal antibody is suggestive that it actually induces dopamine release in greater quantity than normal. And this is the monoclonal antibody, as well as the sera from Sydenham chorea, and the convalescent sera is reduced. So this is in a tritiated dopamine release assay. The activation of CAM kinase 2 is also seen in pandas, and you can see how in the non-pandas cases they are less signaling than the pandas, which is less signaling than the Sydenham chorea when you look at the CAM kinase 2 activation by antibody. And just because it bothers me not to prove every time almost, we do it over and over in the lab, I think I have to prove it to myself just to see if it will be proven again, and it always is. We take anti-IgG beads and we inhibit the CAM2 activation. So the activation is caused by IgG in the blood of these individuals, and BSA does not inhibit it. The initial diagram we had, the antibody binds and induces the CAM, induces tyrosine hydroxylase, and the dopamine release. And this is shown when we actually put antibody into a rat brain intrathecally, and the tyrosine hydroxylase is activated. Transgenic animals also expressing our human monoclonal antibody target dopaminergic neurons in the basal ganglia. And so what is the evidence potentially for the reactivity of the autoantibodies with receptors in the brain, such as the dopamine receptors? Well, we decided to use transfected cells that had dopamine receptors on the surface. And of course, D2 is inhibitory, and that's exactly what happens with the monoclonal antibody, and a great dose-response curve where the antibody actually inhibits at increasing concentrations on this D2 expressing transfected cell. Chorea sera does the same thing. It causes signaling of the D2 receptor. PANDAS sera also causes signaling of the D2 receptor. I'm sorry to go so fast, but D1 also causes signaling, but the D1 receptor is signaled by the D1 antibodies. And we had produced a monoclonal antibody actually from the patients in the IVIG trial. And they reacted, this particular monoclonal antibody, B4C, reacted with peptides of the D1 that we produced, and also activated the D1 receptor in the presence of dopamine about 50 times what it normally would be. So what it's doing is activating not only the dopamine receptor by itself, but in the presence of dopamine much, much more. So you can imagine that if you have antibodies against all these antigens, this is to the D2, and you can see the PANDAS and SC antibodies increase to D2, to D1, and panels that we have, the anti-D1, this is the IVIG trial group, and I know that all of you wanted to see this, that they are decreased to D1, to D2, to the lyso, not to the tubulin. This is an improvement as they improved. It's just the total number of patients that were in the group. And then overall, all 5 tests, they were reduced. And then to go on, and those that worsen, we had patients that were similar in our own lab there. And then when they worsen, the antibodies do not go down when they are not recovering. So I think, just to remind you, there are many pieces of evidence that their antibodies are present, even in some patients that are chronic. There are behavior alterations shown in many animal models, and we have at least 5 of them here. And then Dr. Ben-Pazi's already shown you this wonderful data from Israel, so I don't have to really do that. I think it's interesting to say that in the beginning, it looks as if the D1 receptor antibody may come up and then the D2, but I also want to get on to those that she was showing you from our new study where the anti-D1 is highly elevated in her group of SC, and then her recurrent and persistent. And notice the D2. This is where I was trying to get the recurrent and persistent, very high D2. Oh my, amazing. But look at the pharyngitis, it's also high. And she was trying to tell you this. I just want to be sure you got it, that in the pharyngitis, after a half of a month, it's nothing. There is no antibody in the pharyngitis cases, whereas with the disease, it just continues to go up, as you can see. So again, D1, and Hill has already shown you these, so I'm going to get to the final basis, the signaling and the effects of the antibodies on the D2 and the D1 receptors. This was a kind, wonderful drawing by nature to show the mechanisms in Sydenham chorea, or potential mechanisms in Sydenham chorea, leading to the abnormal movements and behaviors where binding of high avidity cross-reactive antineuronal antibodies to lysoganglioside and dopamine receptors may cause alterations in dopamine neurotransmission, autoantibody-mediated increases in central dopamine levels, and selective activation of D2 receptors and D1 also. Don't count out D1. D1's important, combined to produce altered movement and neuropsychiatric symptoms. And then just to remind you that because I'm an immunologist, in autoimmunity, there are groups of antibodies that go with different diseases. Our antibodies in PANDAS and SC, they don't react with myelin basic protein. There is just no way that they don't react with the gangliosides that are present in Guillain-Barré. And so they are their own autoantibody group. Remember, immune complexes that persist, and you've already heard about the mannose binding protein. And then you also, from Dratan and Dr. Cutforth, heard about the blood-brain barrier, that all of these antibodies are important, but they're really important when the blood-brain barrier is broken and they can get into the brain. And the Th17s being an important part of the story. Remember, it takes not just one thing. We have to think about all the different pieces of the immune system and what role they play in the disease, because all of our studies have a place in that pathway. And I think I would like to thank all the people that have helped all these years, my laboratory, the people from Yale University, from Tel Aviv for the animal model, Dr. Ben Pazzi, who's stuck it out with me all these years with the patients and the antibodies and the ideas, and talking on the phone in the middle of the night when I'm awake. And certainly Dr. Sweeto, who without her we wouldn't have any of this at all. And Dr. Fallon, who talked about some of the work, Dr. Singer, who says he misses me because our paper's already published, and so we stopped talking about these antibodies. Dr. Janicki and Dr. Geller and Dr. Stoner, the statistician, and even Dr. Kaplan, who probably doesn't always agree with my infectious disease ideas, but I think he still likes me. Anyway. Thank you so much.